Deep in the South American canopy, indigenous hunters utilized a highly exigent method to bring down prey, coating blowgun darts in a specialized botanical extract. This botanical compound, curare, causes death by inducing profound, inescapable skeletal muscle paralysis. It leaves the victim entirely conscious, but completely unable to move or breathe. In 1938, an explorer named Richard Gill traveled into the Amazon basin of Ecuador and returned to the United States with nearly 40 pounds of raw curare, intending to see if this potent paralyzing agent could be purified and studied for clinical use. Just 4 years later, anesthesiologists Harold Griffith and Enid Johnson conducted a landmark clinical trial, successfully administering curare to a patient undergoing an appendectomy. Prior to this, surgeons required large doses of systemic anesthetics like chloroform to suppress a patient's reflex muscle contractions. Curare provided total skeletal muscle relaxation independently, reducing the cardiac risk for vulnerable patients. Transforming a hunting poison into a medical tool required isolating its effects to one specific, microscopic battleground in the human body. To see how these drugs operate, we have to plunge down past the muscle tissue, directly into the synaptic cleft of the neuromuscular junction. This microscopic gap, where the motor nerve terminal meets the muscle cell, is the exclusive site of action for all neuromuscular blocking agents. The specific target within this junction is the nicotinic acetylcholine receptor. Under normal conditions, the nerve releases acetylcholine, which binds to these receptors to trigger a muscle contraction. Modern clinicians induce paralysis using two different classes of drugs. These classes achieve the same physical result through two opposite biochemical strategies. Non-depolarizing agents work by silencing the electrical signal, while depolarizing agents overwhelmingly force the signal. The choice between these agents dictates how the clinician will monitor the patient, and eventually how they will reverse the paralysis to restore spontaneous breathing. We begin with the non-depolarizing agents. This class includes aminosteroids like rocurium. This diagram shows the postsynaptic receptor, a 5-subunit ionotropic ligand-gated channel situated on the muscle end plate. These drugs act as competitive antagonists, binding to this complex to physically block acetylcholine. The ion channel cannot open, halting membrane depolarization and leaving the muscle flaccid. There is a secondary mechanism occurring across the synaptic cleft at the presynaptic terminal. This graphic illustrates the complete synaptic structure. Notice the presynaptic nicotinic autoreceptors on the motor nerve terminal. Normally, these create a positive feedback loop, facilitating the mobilization and release of additional acetylcholine during high-frequency stimulation. Non-depolarizing agents also act as competitive antagonists here, breaking that positive feedback loop. Without that mechanism, the nerve cannot sustain high-volume acetylcholine release. This creates a decremental drop in neurotransmitter that manifests as fade on a train of 4 peripheral nerve monitor. Physical paralysis results from postsynaptic blockade, while the fade measured on the monitor is a direct readout of presynaptic failure. The alternative is succinylcholine, the only depolarizing neuromuscular blocking agent in clinical use. Its molecular structure is essentially 2 acetylcholine molecules bound together, making it a persistent agonist rather than an antagonist. Watch what happens at the postsynaptic receptor. Succinylcholine binds to the active sites and drives the channel open, pulling a massive influx of sodium ions into the cell. This binding generates continuous, uninterrupted membrane depolarization. This initial electrical storm across the muscle manifests as transient, uncoordinated visible contractions, which are known clinically as fasciculations. The continuous state of depolarization rapidly traps the surrounding voltage-gated sodium channels in an inactivated state, preventing further action potentials. Normal acetylcholine is destroyed almost instantly by synaptic acetylcholinesterase. Succinylcholine resists this degradation, holding the channels in a paralyzed stall. Paralysis ends when the succinylcholine molecules diffuse away from the junction and enter the bloodstream to be metabolized by plasma pseudocholinesterase. Succinylcholine achieves total paralysis by overwhelmingly flooding the receptors until the electrical system stalls out. To track these mechanisms, we look to the train of 4 peripheral nerve stimulator, which provides an objective, real-time test of synaptic function. This graph illustrates a classic phase 1 depolarizing block. Notice how all 4 twitches decline equally in amplitude. There is no fade in phase 1 because the postsynaptic membrane is uniformly depolarized, while the presynaptic autoreceptors remain unblocked. If succinylcholine is given in massive doses, or if the patient lacks pseudocholinesterase, they transition into a phase 2 block. On the monitor, the phase 2 readout displays a progressive fade with a ratio below 0.3, visually indistinguishable from a non-depolarizing agent. The membrane has desensitized. Through open channel block or presynaptic interference, the receptors mimic competitive antagonism. The specific shape of the train of 4 readout identifies which molecular mechanism is currently dominating the patient's synapses. For clinical practice, these 2 classes of agents fall into distinct comparative categories. Non-depolarizing agents are competitive antagonists that block both pre- and postsynaptic receptors. They reliably generate train of 4 fade and rely on hepatic or Hofmann elimination for clearance. Succinylcholine is an unregulated agonist driving persistent depolarization. It yields visible fasciculations followed by a constant phase 1 block, and it requires plasma pseudocholinesterase for metabolism. While both drugs result in a paralyzed patient, their divergent molecular paths dictate entirely different protocols for dosing, monitoring, and reversal. The success of airway management and the restoration of natural breathing depend on the precise pharmacological control of these nicotinic receptors.